Welcome to Take Health to Heart initiative, which is seeking to advance a policy agenda to stop the rise in cardiovascular deaths. Today, we'll be reviewing recent data and trends related to cardiovascular disease and exploring some of the barriers to care and treatment that are contributing to an alarming rise in cardiovascular deaths and disparities in outcomes among individuals that are underserved populations, with a special focus on Black Americans. Before we dive in, I'd like to introduce myself and our experts for today. I'm Dr. Warren Jones. I'm a family physician. I'm also the Chief Health Officer of the Jones Group of Mississippi. In addition, I am Chair Emeritus of the NMA's Family Medicine section, past President of the American Academy of Family Physicians, and Professor Emeritus in Family Medicine at the University of Mississippi School of Medicine. Today, I am joined by my esteemed colleagues, Dr. Millard Collins and Dr. Hakeem Allende. Dr. Allende is a board-certified cardiac electrophysiologist at the Cardiology Associates of Fredericksburg, Virginia, and a clinical assistant professor at the University of North Carolina, Chapel Hill. He cares for patients with heart rhythm disorders. Dr. Allende also currently serves as the vice chair of the internal medicine section and the co-chair of the cardiology subsection of the National Medical Association. Dr. Collins is a board-certified family physician. He is an associate professor in family medicine and the chair of the Department of Family and Community Medicine at Meharry Medical College. Dr. Collins also currently serves as the chair of the Family Medicine section of the National Medical Association. Take Health to Heart is a national education and advocacy campaign to drive public policy changes that enable better access to optimal care and treatment, advance a more equitable healthcare system, and ultimately stop the rise in cardiovascular deaths. As organizations working to advance cardiovascular health and the interests of medically underserved communities, we're seeking to reach policymakers, providers, patients, and their families with data and insights about the critical access barriers that are leading to poor outcomes, all in an effort to motivate policy change at the state and federal levels. We'd like to thank Novartis Pharmaceuticals Corporation for their support of our initiative. As part of our effort, we launched a digital hub with helpful resources on cardiovascular disease. We published and will continue to publish new research that will help quantify the impact of cardiovascular disease on the states, as well as survey research on the myriad of challenges patients face accessing cardiovascular care and treatment. We have hosted and will continue to host a number of in-person virtual convenings with policymakers and other key stakeholders, and a webinar series bringing together expert and patient voices to highlight the impact of cardiovascular disease on medically underserved populations. Through the digital hub, the detailed state-of-the-heart cardiovascular disease impact and outlook in the United States report is accessible. An interactive map of the United States is accessible as well. This map grades each state, A through F, related to the impact grade of ASCVD. As a nation, the US is nearly failing with an impact score of D. In 2023, Take Health to Heart released the Heartfelt Hurdles, the Cardiovascular Disease Patient Experience report. This report provides details and key findings from the comprehensive survey that sought to understand the lived experience of patients with ASCVD. This report is accessible through the digital hub as well. The Heartfelt Hurdles report showed that nearly 1 in 3 individuals with established ASCVD risk factors, such as diabetes, family history of cardiovascular disease, and smoking, have not been screened. Over 90% of patients with ASCVD had insurance, and prescriptions still experience barriers to accessing treatment in the past 3 months. Nearly 50% of the people of color with ASCVD report being misdiagnosed or giving incorrect treatment in the past year, and 46% report experiencing unfair judgment or treatment based on their race. So now let's turn to the focus of our effort: cardiovascular disease, a national crisis with a focus on Black Americans. So first, let's define what we mean by cardiovascular disease. Cardiovascular disease is a spectrum of diseases involving the heart and the blood vessels. According to data from the CDC, cardiovascular disease is the leading cause of death in the US. ASCVD, or atherosclerotic cardiovascular disease, is the deadliest form of cardiovascular disease. You might know it better as heart disease, or its clinical outcomes of stroke and heart attack. As the diagram on the left shows, ASCVD is caused by atherosclerosis, or the buildup of plaque in the blood vessels and clots, which can lead to heart attack and stroke. Key risk factors for ASCVD include elevated LDL, or low density lipoproteins, or the bad cholesterol, high blood pressure, smoking, obesity, and diabetes. High blood pressure and high cholesterol are the leading modifiable risk factors for premature cardiovascular deaths. According to an analysis of data published by the CDC, an estimated 21 million Americans have been diagnosed with ASCVD, but potentially millions more remain undiagnosed. Cardiovascular disease takes an immense human and economic toll in the US. Cardiovascular disease is still the #1 cause of death among all Americans, killing more people each year than all forms of cancer and accidents combined. 1 in 5 premature deaths among adults ranging in age from 25 to 64 is caused by cardiovascular disease. Cardiovascular disease also has a significant impact on the US economy, with 12% of the US health spending going towards cardiovascular disease care and treatment, the highest among all major disease categories. The COVID-19 pandemic had a profound impact on cardiovascular disease outcomes in the US. According to recent research, the pandemic resulted in 5 years of lost progress in reducing heart disease death rates among adults, a setback we will likely have to contend with for years and years to come. Many cardiovascular deaths are preventable. They can be prevented through better management of risk factors and improvements in screening, diagnosis, care, and treatment. However, despite the fact that we know what works to prevent cardiovascular deaths and we have effective treatments available, after decades of decline, deaths are once again on the rise. So now let's turn our focus to the United States. Nationally, the US gets a near failing grade in analysis measuring the impact of cardiovascular disease. This map clearly demonstrates that in states where many Black Americans reside, the impact of cardiovascular disease is the greatest. Take a look at my state of Mississippi. With the exception of Georgia and Virginia, the greatest burden of cardiovascular disease is in the southern US states. Looking specifically at the impact of cardiovascular disease and related risk factors on underserved populations like women, racial and ethnic minorities, and rural Americans, we see evidence of undertreatment leading to disparities in outcome. For example, among people with ASCVD, women are 28% more likely to have 2 or more hospital emergency visits each year compared to men, Differences in the presentation of symptoms in women compared to men may contribute to providers misunderstanding and underestimating the cardiovascular disease risk in women, resulting in suboptimal care. Rural Americans also experience worse outcomes, with research showing that rural areas have exhibited greater cardiovascular disease mortality, with the absolute difference between rural and large metropolitan areas nearly doubling between 1999 and 2017. Significant disparities in cardiovascular outcomes also persist among racial and ethnic minorities. For example, Black and Hispanic Americans face higher rates of hypertension compared to white and Asian Americans. And Black Americans are 33% more likely to die from cardiovascular disease than non Hispanic whites, are 85% more likely than Hispanics, and 136% more likely than Asian Americans. The impact of the COVID-19 pandemic was also particularly pronounced among Black Americans, who experienced approximately 10 years of lost progress in improvements in heart disease deaths. There are a number of critical barriers to care and treatment that are contributing to these poor cardiovascular outcomes. Clinical practice barriers are impacting the quality of care that patients receive from their physicians and leading to poor management outcomes of critical risk factors for cardiovascular disease. In particular, in 2013, the American College of Cardiology and the American Heart Association cholesterol guidelines removed LDL cholesterol goals, resulting in quality measures that focus on statin use rather than treating to evidence-based targets. This contributed to poor risk factor management among patients with cardiovascular disease, with just 1 in 5 patients currently taking statins ever reaching healthy guideline recommended levels of LDL control. Research suggests that social determinants of health, the social and environmental conditions that determine an individual's health behaviors and risks of disease, are strongly tied to cardiovascular outcome. Social and economic barriers, lack of education, poor housing conditions, and limited access to healthy foods increase the burden of cardiovascular risk factors and poor outcomes like stroke, heart attack, and death for underserved populations. Insurance barriers in the form of practices like prior authorization, which are requirements by health plans that make providers get approval from the plan before a patient can get a certain service or a certain treatment. And this can lead to delayed, suboptimal, or abandoned treatment and hospitalizations and other negative outcomes down the road. In fact, according to a survey of physicians conducted by the American Medical Association, over 90% reported delays in patient care due to prior authorization policies, with nearly a quarter of physicians reporting that these policies specifically led to the hospitalization of a patient that they managed. Health system barriers stand in the way of healthcare stakeholders leveraging collaborative models to improve patient outcomes. For example, value-based arrangements hold significant promise in improving patient access to innovative treatments by linking reimbursement to patient outcomes instead of the volume of treatments dispensed. In one assessment, patients with providers that participated in value-based arrangements had better medication adherence and lower out-of-pocket costs. However, a recently implemented policy change could impact the ability of stakeholders, particularly providers, particularly, that's an awkward phrase. Okay, we start with however. However, a recently implemented policy change could impact the ability of stakeholders, particularly providers for which there is uncertainty if their reimbursement rates may be impacted, to participate in these innovative payment models. So the evidence is clear. Cardiovascular disease remains an urgent national crisis that requires collective action. It requires it now to address the access barriers that are leading to poor outcomes like heart attack, stroke, and death. To that end, our initiative is introducing a policy agenda to stop the rise in cardiovascular deaths. Our agenda is driven by four key priorities that we believe are necessary to lead to lasting change in cardiovascular outcomes. First, we need to improve the quality of care for patients with cardiovascular disease. And we can do this through updated quality measures that encourage patients to control modifiable risk factors like LDL cholesterol. Second, we need to better address the socioeconomic barriers that contribute to significant disparities in cardiovascular outcomes. And we can do this in part through increased funding and use of programs that improve access to screenings and services for underserved populations. A key example of one such program that is really finding success in a growing number of states across the US is the CDC's Wise Woman program, which provides low income, uninsured, and underinsured women aged 40 to 64 years with heart disease and stroke risk factor screenings and services that promote healthy behaviors. Next, we need to ensure broad, appropriate, and timely access to care and treatment for patients with cardiovascular disease through reforms to prior authorization policies that are leading to delays in care. For example, creating a more expeditious and/or transparent prior authorization process, exempting certain providers from prior authorization requirements, known as gold card policies, or some combination of these and other approaches at the state and federal levels can help patients better manage their disease and prevent deadly cardiovascular outcomes. Lastly, we need to enable healthcare stakeholders to collaborate to address population health challenges through policies that encourage the use of value-based arrangements, which show promise in improving patient access to innovative therapies. Now, I'd like to turn to our distinguished panel for discussion of these topics and further explore some of these points. I'd like to bring back Drs. Allende and Dr. Collins. Thank you again for joining with us today, and we look forward to your sharing your informed viewpoints with us. My first question is for you, Dr. Collins. As clinicians, what do you think are some of the biggest factors behind the rising number of cardiovascular deaths?
Well, Warren, I'd like to thank you for a very clear and concise presentation, but as a Black male, it's also very disturbing. I think the rise in cardiovascular deaths are multifactorial. First and paramount is the distrust. The distrust continues, the distrust of the system, distrust of the medications, and distrust of just that doctor who patients are assigned to somewhat arbitrarily on the card for most people of color. I think being an African American physician, I think the lack of diversity in medicine is also a barrier. People of color would love to go to people who look like them. And unfortunately, the 13% population, 5% of those in medicine, there's clearly a mismatch there. We've long known about the trends of healthcare disparities and all of those modifiable risk factors, and unfortunately, those non-modifiable risk factors that you spoke of have always affected people of color, and all those contribute to cardiovascular death, mainly stress, diabetes, and tobacco use. But the biggest one that I think is because of the lack of access is the stage of presentation, stage of disease on presentation. By the time most people of color do present for intervention, it's too far gone, requiring multiple medications that makes it very, very costly. Unfortunately, has led to the bad outcomes that you spoke of.
Thank you. Dr. Allende, I just want to give you an opportunity to share your thoughts on the same question. What do you see as some of the biggest factors behind the rising number of cardiovascular deaths?
Yeah, thank you for the question. It's this is overdue to talk about such an important topic, especially since we've seen the changes in the trend where we had been seeing some gains in the past, but it looks like we have had a reversal of a lot of the gain we had in cardiovascular mortality in Black Americans. And a lot of that has to do with risk factors that, like Dr. Collins said, and it's not just risk factors. For example, when we look at base, you look at risk factors: hypertension, obesity, high cholesterol. Uh, these things are more prevalent in Black Americans and increase the likelihood of coronary disease, cardiovascular disease. Not only that, for example, if you look at the regard study that was looking at, okay, say uh, they looked at uh, Black and white populations with similar incidence of coronary disease, but they found that Black Americans are more likely to have fatal coronary disease despite a similar incidence compared to white persons. Or when you look at a case like, look at cholesterol, for example, there was the regard study that showed that Black Americans are like up to 33% less likely to have controlled cholesterol compared to white Americans. And a lot of this it's not just about, oh, we can't control the risk factors in people of color. That's not what it is. That's when we start to look at factors like Dr. Collins was talking about, the socioeconomic factors. You look at access, you look at health literacy. I think a quarter of Black Americans live in poverty. I mean, you see how that affects health. So when we talk about addressing these factors, don't look at just the medical aspect alone. We have to look at it also as a socioeconomic problem.
Thank you. Dr. Hande, why do you think the pandemic had such an outsized effect on Black Americans compared to the population overall?
Well, again, we have to go back to the socioeconomic problem. I mean, we're gonna keep it always comes back to that. It's not like, oh, Black people have genetic predisposition to die more than, no, that's not what it is. These are just the disparities we face. For example, if you look at COVID, we realized quickly, I mean, I guess that was the first time a lot of people heard about frontline workers. We see that Black and Latin and other ethnic minorities were overrepresented in those low status frontline jobs that had reduced protections and increased likelihood of contracting COVID to begin with. So, but it was not only just catching COVID and dying from COVID, but when you also look at this is where also the health access comes into play. For example, I remember at that time a lot of practices had shifted to remote. You couldn't get in to see your physician for your regular follow-up. You couldn't get your usual preventive screening. So a lot of things shifted to remote. And say you have somebody who doesn't even have internet available to make a remote visit happen. So you start seeing other layers of disparities start getting peeled back, and you started seeing a widening of the gap. And this was mainly also based on socioeconomic disparities, which COVID really showed us.
You touched on a lot of key topics, and Dr. Collins, I want to give you a chance to share your thoughts on the impact of COVID and why there was a greater adverse impact in people of color.
Well, like Dr. Yin, I'm not really shocked. We heard about all kind of pandemics and crises, the opioid crises, but the pandemic, the COVID crisis, but the healthcare disparities has always been a crisis, something that we've been aware of. And as he mentioned, it exposed a lot of things that we already knew. But unfortunately, for the reasons that we talked about in question number one, many people of color, due to lack of access, lack of trust, et cetera, are not aware of where they are in terms of the healthcare spectrum. So this kind of really just exploited weaknesses that maybe subconsciously they knew, but we really didn't objectively know. So when we talk about healthcare disparities and how COVID had a tendency to attack those that were already infirm, there were two different starting points.
Yes.
Fortunately, that's the way in which a lot of these disparities come around full circle. We just didn't start from the same place. Um, I didn't even think about it until Dr. Yende mentioned it, the fact that we were on the front line. So
Yes.
that charged us with the duty and the obligation to continue to put
Yes.
ourselves in harm's way for the greater good, which unfortunately did not represent us to that magnitude for the positive, but more so for the negative.
And I'm sure that you gentlemen had an experience somewhat like mine of a patient that I cared for way back in the 80s who called me asking for guidance on what to do. And she had been to the emergency room 5 times and sent home. And when I heard her on the phone, I looked up the one hospital in her region that was taking care of COVID patients and told her husband to take her there. She was admitted and died within 18 hours. So when you look at the fact that the access to care played a big role, okay. So one of the things that our policy agenda has to do is make sure we eliminate the barriers of access to care. Uh, I think about all of the challenges we face. And Dr. Collins, I want to ask you, we've talked about some of the the things that are occurring with people of color, but why do you think that there are more challenges facing adequate and accurate and timely diagnosing and treatment of patients of color compared to the rest of the population?
Well, Dr. Jones, as we've been talking about, when you know better, you do better. And unfortunately, we don't know. That lack of access, lack of trust, and you're going to hear that over and over again, has been a big, big part of the outcomes on the back end. But the biggest thing is the delay, the delay in diagnosis, delay in treatment, the lack of offering, quality medications to us. We're treated differently by a lot of patients, and there's many documentation on how we treated differently for pain, but also from just access on a symptom-based perspective. But the delay really, really has caused an increase in the morbidity and the mortality as it pertains to cardiovascular disease. Um, and if we really want to get down to it, why do people have a tendency to want to change something that's been done over and over again? They're not doing it because it's the right thing to do. People are always, black and white and others, are always subject to their own bias and experiences,
Yes.
what they've been encountered. Something Dr. Allende mentioned, we have to break it down to a socio-economic level to make people have to care by holding them accountable. And hopefully that's where the future is going.
Thank you very much for that. And Dr. Allende, I didn't know if you wanted to add something to that.
Yeah, I like Dr. Collins mentioned, the socioeconomic is probably the biggest aspect of it. But even when we go back to the pure medicine and prevention and screening and all that, if you look at a lot of, say, we look at coronary disease or a lot of other things like atrial fibrillation, a lot of these conditions, you realize that the screening tools that were developed, a lot of them were developed in mostly white populations. And they're actually, for example, look at the Framingham risk score for coronary disease or cardiovascular disease. You find out that a lot of this score, for example, actually tend to show lower risk in general for African Americans, which is not necessarily the case. So we get a lot of times when Black Americans present to your healthcare provider and stuff, and maybe they mean well, they check do their due diligence, check this scores, but like, no, you appear to be low risk. So I think sometimes what we have to do is start by addressing the disparity, even from the medical, from our medicine standpoint, say, okay, let's look at all these risk scores. Let's look at all this. I mean, most conditions, I guess things are changing now, but most conditions, you look back, you look at commercials in the past, it's gonna be the picture. You will not see the picture of a Black American as representing cardiovascular disease, say like a decade, 2 decades ago. So it wasn't like Black Americans weren't dying more of cardiovascular disease. It was just that, no, they were telling us in medicine that no, it's the, there's a lot of subliminal things. You don't, I see a picture on a bottle. Oh, this represents the people that should have this disease. So those subliminal things gets passed on, and that's kind of feeds into the structural racism that you can't really hold on to, but they exist. And I think another factor to look at is also the one thing. I think Dr. Collins mentioned it briefly, but I think we should also speak more about it, and that's increasing the representation of Black, Black people in medicine. Like, we need to have more Black clinicians, more nurses, more people that look like the patients they treat. I mean, we've seen a lot of studies show that when, that cultural sensitivity actually helps to increase, improve outcomes in these patients. So I think those are just the two things I'll add to what we've said so far.
I think those are excellent points, gentlemen. I just ask you to consider one other thing. Many times the measures that are employed, the populations that were studied did not include high representations of people of color. So one of the things we've got to do is create a better willingness to participate in clinical trials to demonstrate the efficacy in our populations. I want to ask you both just to share with us briefly your thoughts on the challenges you face with prior authorization. And I know it has a wonderfully positive impact on your ability to see your patients and get them to the care that they deserve. Am I correct? Dr. Collins, starting with you.
As a primary care physician, Dr. Jones, you hit the nail on the head. It seems to be more of a deterrent and not an enabler. It seems to happen disproportionately to more people who are either uninsured or underinsured, like people of color, than our counterparts, and it just falls through the crack. We all have personal tales, whether it's heart disease or whether it's cancer, where it's a time-sensitive game that we're playing, and we need to get that patient over. And what happens is nothing happens.
Yes.
Fortunately, the cheat code, which a lot of providers is getting their attention, and I know we'll touch a little bit on value-based compensation, is people who have patients who can't access the specialist that they need, they're being told to go to the emergency room and go to the hospital. Yeah. And that's very unfortunate, but literally, if it's a matter of life and death, I think that's what defines an emergency.
Yes.
Most cost effective, but it's also presents its own unique challenges because some don't want to go because of those upfront costs.
Yes.
But it's just a problem in prioritization, and how it happens and who it happens to needs to be looked at very closely.
Dr. Ayande, your experience?
Yeah, it's a battle. There was the study that showed that more than 90% of physicians, struggle with prior authorization. I mean, we just, and it's so frustrating because, when you say I'm trying to order a test or a procedure, a lot of times we do this because we're trying to prevent a negative outcome down the road.
Yes.
We're trying to prevent that ER visit, because I promise you, the insurance company doesn't want the bill of a hospital stay. You want to, as much as possible, do all these treatments as outpatient because it's cheaper. Unfortunately, we get faced with this barrier. For example, I have a patient. He has significant cardiovascular disease. He has heart failure, coronary disease, and he has a hernia. And it's been, challenging for him to walk. So he sees a surgeon who says, if we do surgery for your hernia, we can improve your quality of life. Great. Now it comes to me for a pre-op evaluation, and there are things we need to do to help optimize him and get him the safest surgery possible, except insurance is going to tell me, oh, well, you can't do this. And so I'm doing this to help him get his surgery, get him a better quality of life. And I get stuck at that point because of prior authorization. And you see how much and this is just one example of, luckily after multiple appeals. We ended up getting the test approved, and he's going to go ahead for his surgery. But that's just one good story, which unfortunately, you hear one good, you hear a lot of bad outcomes, say delay in care. Sometimes that delay is enough to either cause permanent complications or injury, or even have a patient lose their life. So I think, Dr. Collins, the important thing which you keyed on was delay.
Yes.
Delay is what we need to get out of the system, because delay could be what costs the patient's life.
I'm loving this dialogue, but I'm going to have to put you guys on speed dial. Okay. Let's talk about value-based arrangements. I'd like to know what both of you think about how these may aid us in helping to improve population-wide healthcare delivery. I'll start with you, Dr. Allende.
So, Dr. Jones, that's I think when you hear value-based arrangements, I think they sound great. They sound great on paper. They sound, and it makes sense. If we're gonna incentivize physicians or healthcare systems to try to improve outcomes, so you're paid on, your overall outcomes. Say you're able to, in your general population of patients, reduce, get majority of the patients high blood pressure controlled, an example. You get incentivized to do that by getting paid, etc. Now, one thing while it's great, one thing we have to be careful about is sometimes if I'm like I'm a health system administrator, for example, and I want my numbers to look good because I want to get paid, then I got to start cutting the weak links. Where are the weak links? Okay, which patients are the ones I deem non-compliant? Which ones are less likely to have their blood pressure controlled, their diabetes controls? Those are the ones that are likely to have lower socioeconomic status, lower health literacy. And by the time you start looking at it, you're like, no, those are actually underserved patients. So the worry I have for value-based arrangements is that if we do not put, if we don't put safeguards in place for these patients, again, what we're going to end up doing is we're just going to actually hurt the, the people that at the highest risk, social risk in the community. And that's what I think we should pay attention to when we look at the bigger picture.
Dr. Collins, your thought briefly?
Not much to add. I think he said it perfectly. I know there's a whole not in agreement. It seemed like a good idea at the time, but they don't account for the fact that we're starting from different locations. At my institution, we treat poor people, and we take on the greater risk. And you have other institutions that stay away from those. And again, Dr. Yende said all the things I won't repeat, but they're causing us, if we want to maintain a financial viability, we're going to have to start to look more like them in terms of people of color. So my concern is that if they don't reimburse those who take a chance on those and make it something that everyone want to participate in, that disparities gap is going to actually widen.
Yes. And one of the things that you gentlemen can help to influence is the understanding of just what those outcomes that people are talking about look like. Okay, if the outcome is doing a hemoglobin A1C in a certain time period, and I've been taking care of Miss Williams for 5 years, I know from her weight, I know from her fasting blood sugar that her hemoglobin A1C will not change, but I'll get dinged for not having done a hemoglobin A1C. It's that's the kind of thing that experienced clinicians struggle with. Now, a part of what we talked about earlier were quality measures. How could changes to quality measures related to cholesterol management help to lead to better outcomes for patients, Dr. Allende?
That's a good question, and I'm happy that that's one of the things that the initiative is looking at. Is, when we talk about the LDL lowering, which is at least in treating cardiovascular disease, that's one of the foundational principles, lowering LDL. Yes. And now I know that current guidelines, we started with, lowering LDL, then we went to, okay, but because we know that statins have they work not only by LDL lowering, but they also have positive effects like anti-inflammatory effects that stabilize plaque. So they also, in that way, reduce coronary disease. Then, we kind of went away from, targeting low LDL. But here's the thing. We know that the lower your LDL, the less likely you're going to have an acute coronary event. So lower is better, because one thing we're seeing with just not having a number on the lower is you're having people say, oh, you're already on a statin, check. But that's not enough. Think about it. Let's say high blood pressure. Is it enough to say, oh, you're already on amlodipine or something? Oh, check. No, I want to make sure your blood pressure is a target. Yes. So because that is how we reduce the complications of high blood pressure. So the same thing, at least in my practice, I try to make sure, depending on the risk, high risk patients get your LDL less than 70, the lower the better. If you have to do multiple medications to get it, because the outcomes are there.
And Dr. Collins, your experience?
Quickly put, I think you said it perfectly. I think when they set these, I'm not going to say arbitrary guidelines out there, I think we need to realize that the patients that we serve are not average risk patients. And we need to, just like the PSA in African Americans, we need to do something, because if, just take in 20 seconds, if that, we need non-pharmaceutical approaches to really pushing lifestyle changes in people of color. We need to use social media, use our faith-based organizations to really, really get those changes and get people's attention. And it's platforms like this that's going to highlight the problem for the lay people, not just the clinicians.
That's great that you would help us. You must have been looking at my sheet, because you gave us a natural transition to our final question of the day. Why are target programs that care for underserved communities, like the CDC's Wise Woman program, why are there not more like those? And what are some of the critical steps that are being done with programs like that can help to improve the disparate outcomes in the management of cardiovascular disease and risk? Dr. Collins?
It all comes down to the funding. If there's no funding to support these programs, because maybe the funding source doesn't value the people, if the insurance companies and the clinicians come together and realize that, wait a minute, if we fund this program, we can reach those targets and we can get more money. You have to kind of go back to what Dr. Yannis said, the socioeconomic effects of this. Where I'm from, I know Dr. Jones, I know you can relate to this, being from the South as well. The squeaky wheel gets the grease.
Yes.
And this is very unpopular for me to say, but I think it's worth saying. When God sent his son down to make a difference, he sent him to where the people with problems were. And that's where he can make the most difference. So I think we need to have that approach, and you need to incentivize those individuals to put their money where their mouth is.
Yes. And Dr. Ayande, your thought?
Yeah, I agree with Dr. Collins. It's, these programs are very important, like the CDC Wise Women program. You look at women who are, less insured, middle-aged, risk factors for cardiovascular disease. How do we teach you to minimize your risk factors and reduce complications? Because where these things come into play, and the problem is, I think when you take a step back, remember, I think COVID showed us in this country that we don't have a great public health and prevention infrastructure. What we have is a great treatment of complications, like a secondary prevention or treatment or tertiary treatments. That's what we're good at. And it's unfortunate, because if you can have upstream prevention, you can actually really, really lower healthcare costs. When you catch them, say, if you look at numbers, for example, I was looking at numbers on hypertension in African Americans, and you realize that we start to diverge at a younger age, like in the teens to the 20s, you start to see the increasing prevalence of hypertension. Those are things that when you see that from that young age, you have programs that can catch that and
Yes.
prevent, so that's where disparities are, right? So if you can catch it upstream, and the cities wise woman is one example of it, put some money in these programs, and you may not, unfortunately, you may not see the numbers right away, but down the road, decades from now, you are likely to see the reduced incidences of cardiovascular disease and stuff. So yeah.
As you said, gentlemen, the longest journey starts with that first step. Um, Supporting the Wise Woman program, I can tell you a personal story that if a program like this had existed, my daughter, who died at 46 years of age of heart disease, would still be here, because she would have been driven to a system where she could have gotten appropriate care from being pushed by someone other than daddy. Okay, so we got to find a way to get people in to make sure that they're treated. I want to thank you for spending this time with us today and sharing your insight and your professionalism. I can tell you that the kind of information and the experience that you gentlemen bring to the table and compassion you have in your practices are what we need to have to help to make sure we can deal with the scourge of cardiovascular disease. So thank you for being with us. So as you just heard me offer a good thank you to my friends, Dr. Ayande and Dr. Collins, for their insightful commentary. But before we sign off today, I'd like to invite you all to connect with the Take Health to Heart initiative. You can access our digital source, our resource hub, at www.takehealthtoheart.org, or you can connect with us on X, formerly Twitter, by Take H, capital L, capital TH. You see it on the screen, or you can meet us through LinkedIn on Take Health to Heart initiative. And you can go there to sign up to get information. But most importantly, you can also go there to share your stories of what you've experienced. You can also share some of that experience with us by sending a letter or an info to info@takehealth.org, so that you can share stories in your family, like what I shared about my daughter. The reality is we can make a difference in dealing with cardiovascular disease that not only add years to your life, but add life to your years. And together we can make this happen. Thank you again for being with us today.